Hello, everyone. Good afternoon. I'm Julie Livingston here for the Quorum Initiative for another of our Quorum Lives, conversations with Quorum Initiative members and friends on topics that really matter to professional women. Today, I am thrilled to welcome Dr. Barb DePree. She is an MD, and she has been a gynecologist and women's health provider for almost 30 years and a menopause care specialist for the past decade. Barb was named the Certified Menopause Practitioner of the Year by the North American Menopause Society for exceptional contributions to menopause care through the outreach, communication, and education she does through her company, MiddlesexMD. And her work as director of the Women's Midlife Services at Holland Hospital in Holland, Michigan. Welcome, Barb.
Thanks for having me, Julie.
You know, menopause has been making its way into the mainstream conversation. I'm sure you've all been seeing that, and which is pretty exciting because for decades it's been really a taboo subject that we really didn't talk about publicly. We're seeing, new celebrity endorsed product lines like Stripes, which is connected with Naomi Watts, and other newsmakers like Oprah Winfrey and Gayle King and Drew Barrymore, who's a little younger, talking really openly about menopause and what they've been going through, the shame that's been kind of associated with it historically. So why is this and female sexuality in general such an uncomfortable topic for most women to talk about?
Well, I think, the women you mentioned and so many women who now have more of a voice in our culture experiencing menopause are ready to elevate the conversation and make it known that it's not this dark underworld experience that we can't talk about. And I think we have more female providers in the out in the medical community who are more eager and willing to have the conversations. I think it's just a lot of factors. It's the dissemination of information that's more readily available. We're not depending on our 6:30 nightly news for all of our news feeds
Right, we could just
anymore.
go
We just got
online and ask a
multiple
question.
sources. Yeah, so it doesn't have to be a headline news to make it important to communicate about. So I think it's a lot of things.
It's a good thing,
Good
for
things.
sure. And what are some of the most common fears, myths, and misconceptions that you see in your practice and your work that women have about menopause?
Well, I think it starts out condensing menopause to something as simple as night sweats. And that's probably hot flashes, night sweats are commonly seen as the common denominator for menopausal related symptoms. But now we've come to understand it's so many symptoms more than that. And I think, it was seen as, well, everybody does it. And, you just don't worry, honey, you'll get through it and bear it out and things will get better. I think it's a combination too that, women have more, maybe more. I don't want to denigrate our mothers and their responsibilities at this time in their lives, 20, 30, 40 years ago. But I think more women have more responsibilities around work and, caregiving for parents and child care for their own children and grandchildren, just more responsibilities that they have fewer margins in their life to tolerate the symptoms that go along with menopause and are now demanding more answers and treatment options. I think the WHI really kind of shut down the conversation for many, many years. That was published back in 2002. It was headline news press in July 2002, which really set the world back on safe and effective treatment options at that time. And I think women just for a decade or more just stepped away thinking, well, I don't have a treatment option. There's nothing out there for me anyway that's safe and effective. So, what am I going to do? And I think the good news is we're emerging from that headline news. We've expanded our knowledge about really menopause, hormone therapy, the women who are good candidates for it, the safety for it, the other health factors that are impacted by menopause, and why women maybe should be having a conversation about treatment options.
But also, isn't it true that it was sort of a dirty subject right? Women, when we go through this, it doesn't always feel so good. So,
Yeah.
it's just been something like, I don't want to talk about it.
So 80 or more percent of women experience bothersome menopausal symptoms, and only 25% of women seek treatment for it. And then, that's general
That's
menopausal
amazing.
symptoms. But then we talk about women's sexual health, and it's even a much smaller subset of women who are willing to um, go to a provider or try to find a solution for that. The other thing that happens with sexual function and sexual health is sometimes those symptoms are. Um, they start a little bit more remote from menopause. Why hot flashes, night sweats are generally within the first weeks or months of perimenopause into menopause. Um, a sexual function might not be impacted for 5 or 6 or 10 years later. So some women don't recognize it as a menopausal related symptoms, expect it to be part of aging. And so they don't know how to have the conversation or don't know where to go to have that conversation to
Right.
ask about treatment options.
I mean, I'm so glad you said that. I mean, menopause is tricky, right? It
Yeah.
doesn't happen in one day or a week or
I
just one
know.
month.
Yeah. And the other thing is, we've really started to talk about perimenopause as a thing. I mean, that wasn't a term, at least, 20 years ago, even we were hearing much about, but now it too is being defined as a time where women may begin to have some changes that impact her day to day quality of life.
And when can that occur?
Generally speaking, any woman 40-ish or older, median age of menopause in the US is 51, but the range of normal is age 40 to 58. And women spend some years, 3 to 8 years, as in perimenopause. So certainly women mid to late 30s, more clearly over 40, when they're starting to have symptoms that may be hormone related, we really should be thinking about perimenopause.
Wow. So we're talking about a pretty long stretch of time between
Yes.
perimenopause and menopause.
It really can be. It can be. And I think that's why we really want to elevate this conversation because it's not a 3 month, encounter with it. I think about, times of, postpartum and breastfeeding, and there's a defined time where trying to juggle things and make things workable, and um, but it typically isn't 8 years. Um,
You're right.
and so the other thing that's emerging is I'm just involved in a publication that looked at menopausal symptoms and sleep. And then
Mm.
in turn, what that means for productivity, work productivity, and even leisure time activity. And really, it's a significant impact. It was estimated in a publication in 2021 felt in the US there was a $2 billion economic impact for women perimenopause, menopausal who were it was lost productivity between absenteeism and just the quality of their work, and women choosing to leave the workforce. In the UK, 45% of the workforce over 50 is they're women. And so economically, we can't really afford not to support women through this either. And so the UK is really ahead of the US in acknowledging this. As a matter of fact, my 30-year-old daughter works for a UK company. And about a month ago, we had dinner and she said, Mom, I have to do this menopausal training program for an hour. And it's like, oh, yeah, honey, good for them. We're hoping that the US will come along and recognize, again, personal impact, economic impacts, social impact, and just give women the attention they need to support them and help them be successful in navigating it.
Wow. That's incredible. That's so forward thinking. I can't
Yeah,
almost can't even imagine that happening here in the
yeah,
States.
yeah.
Wow.
No, I don't know if it will be in our lifetime, but we can hope for that.
Right. Right. So menopause symptoms really can affect women at work.
Yes, but I think even more significantly, if I'm going to reference some notes here, but a recent publication just within the last 4 to 6 months looked at menopausal symptoms and the risk of heart disease. So here's the unspoken part of and not well understood part of menopause. I think is It's not just an inconvenience to women and their quality of life, but we now are understanding that it has health consequences. So this was a publication, again, recently, 80,000 women were followed for 8 years. And listen to the symptoms that women reported and were correlated with cardiovascular disease: night sweats, waking several times at night, joint pain or stiffness, heart racing or skipping beats. I hear a lot of that. Dizziness, feeling tired, forgetful, mood swings, restless or fidgety, difficulty concentrating. When women had some combination of those symptoms, they had significantly more cardiovascular disease, and there was a greater mortality and more heart disease as a result of that. So we're really trying to understand this as a more comprehensive physiologic occurrence, again, outside of the nuisance it causes at the time, and understanding the impact to the the human system of cardiovascular disease, your brain. We know there's an increased risk of type 2 diabetes, a number of things. So when you look at the WHI, it had some news headlines that made women pause, but when they looked back at that data published in 2018 and they revisited those women, all-cause mortality was lower in the hormone therapy women versus placebo. So in the end, when they looked at all-cause mortality, women did better if they were on hormones versus placebo. It was a breast cancer story back in 2002, but we're really much more than that, as a human female.
Wow, you're bringing up so many questions for me. Well, first of all, in terms of hormone replacement therapy, where do things stand right now? And what do you recommend for some of your patients?
I think the list of contraindications for women considering hormone therapy is really, really short. Generally, women think, oh, my mother had breast cancer, I shouldn't do hormone therapy. Yep, not true. Oh, I have hypertension, I shouldn't do hormone therapy. Nope, you can. Diabetes, nope, you can. So I think there's a misperception about women who could safely take hormone therapy. So that's where I'd encourage women to have a conversation with their provider about the possibility of considering that. It is still seen as the most safe and effective therapy for menopausal symptoms. 26%, I think the number is 26 or 28% of menopausal women have joint pain as their most bothersome symptom. Who knew? A lot of women aren't aware of that. That totally, if their sleep is impacted by joint pain, their ability to be active and exercise, which in turn impacts weight. So many things kind of cascade out from menopausal symptoms. So I think we just want women to connect the dots about what they're experiencing and that it may be hormone related. We've also come to better understand that the timing, there's something called the timing hypothesis or window of opportunity. It's safest to initiate hormone therapy in the first 5 years of menopause or 5 to 10 years of menopause. We don't feel like we add any additional significant risk. And obviously, that's a time most women are having most of their symptoms
Right.
anyway, but the WHI highlighted that a remote initiation of hormone therapy 10 years or more may pose some additional risk for women around
Let,
brain health and cardiovascular health.
let me ask you this. There seem to be so many things that come up for women during perimenopause and during the menopause years that we kind of need to start tracking, doing a better idea of a job at tracking for ourselves and also for our healthcare providers, so that when we go for our annual visit or a call because of a specific issue, we know what we have a list of what's going on. What do you recommend to patients? I mean, what's the best way to track your menopausal symptoms?
It's interesting you say that because I think I have it up right here. Menopausal apps you should know about.
Ah,
Um, so this was put out by Everyday Health just recently, and I will, it won't be a complete list if I try to recall it. So I will tell you which ones, which I am familiar with most of these. Evernow was one. Midday. Midday is the one I know best. Anne Garnier, brilliant woman. She has created an app. Caria, Balance, Perry. I know about Perry, but Perry was designed more for perimenopausal women. Those are the ones listed. And what those allow women to do is, it's a list of symptoms and then allows you to track. So I don't know how necessary an app is for women to, communicate to me how they're being impacted by bothersome symptom. I tell women, do what's simple. I don't want you to diary. I don't want you to do something complicated, but I do want to hear, when are they occurring, where in your cycle, how often, how is it impacting you, which symptoms are worst. So, trying to assess women. I think the biggest thing is a lot of women just don't know what symptoms are associated with
Right.
perimenopause and menopause. I think the other important thing that has emerged is the mood as a disruptive symptom. And, again, I think we've attributed to stress and, marriage partners or work stress or I don't know, but it really, the brain, there are changes in the brain that are impacted by hormone fluctuations and changes. So to not just discount it as stress and, have your marriage break up as a result of that.
Right. So there is a lot of what you're saying, what you're affirming is that there can be a lot of stress that women feel as a result of going through these big changes in our bodies. How can we manage the stress around it? How can we
Yeah.
better understand it? Are there books that you recommend, or are there other resources?
Um, One resource I might recommend is menopause.org. It's the North American Menopause Society website. They're an organization that exists for education
Right.
around menopause. My comment to women is if you have a symptom that you think is related to hormones, you're probably right about that. I mean, we've just spent 35 years living in our bodies, doing hormones every day for decades. It seems like we might understand what something might be related to a cycle or a hormone, right? So I think we should never discount women's understanding of what they're experiencing. I just had a consult from a woman. She's faculty at Harvard for vertigo. Um, and we have data to support vertigo can be a menopause related symptom. Again, not common, but we don't want to discount that person from, seeking treatment or getting treatment or exploring that as a possible consideration. Again, not everything
Right.
belongs in the hormone bucket. Not everything is going to, not all roads lead back to that. But I think it deserves exploring with women, that might be a connection.
That's really valuable information. What are some of the questions that women should be asking their healthcare providers when they do go for their annual checkup, or if they're not feeling well? I know for myself, I tend to get white coat syndrome. So when I do go to the gynecologist, for example, I can freeze. So I often bring a list with me.
Yeah. Yep. A list is great. We give women a list of symptoms. That's pretty expansive to check it. Is it mild, moderate, severe? You're, not at all. And again, it's associated with what we might expect to be hormone related. And some women are surprised at the list, and it helps enlighten them. So, the other thing we have this preparation for what to expect when you're expecting, and almost every pregnant woman knows about it and reads it. I think we'd really like 35 to 40-year-olds understand that beginning to educate themselves about what's ahead will probably serve them well. I can't say there's a single resource in my mind that exists that's the equivalent of that book that we all read, Anticipating Pregnancy, and women still do, by the way. But I think starting to understand how things might change. And I also think it is a time absolutely that details matter more. And I think, we've kind of been busy attending to kids and spouses and parents and jobs and
Right. It's the
a
whole
lot.
caregiving thing that really pulls at women,
I
is
know.
women specifically.
I know. And I will tell you, almost every conversation I have with women, when it's about sleep, when it's about weight, when it's about stress, kind of all roads lead back to exercise. And so I think if women can do a single thing to invest in the years ahead
It's
of them,
exercise.
that's going to help them navigate it and maybe mitigate. I'm not going to say alleviate or eliminate or prevent, but to make some impact in how they experience this transition, I would say invest in exercise. And
That's amazing. That is phenomenal, Barb. I really appreciate that.
and
I
I
mean,
think
it's something I'm impossible about. I do it for a while and then I stop, but
and I think, it's one thing to learn about it when you're 55, but it would be so much better to know it when you're 37, to really
yeah,
kind of get ahead of it, because once we're chasing it, it's just not
it's
exactly the
harder.
same. It
No, it's so much
is.
harder. So, would you say that women, what, in their late 30s should start reading up about perimenopause and what's
Mhm.
down the road for them?
Yeah, I would. Yep, I think that's a good idea.
Yeah, no, that's really helpful. I would like to address something that came up in the news yesterday, and that is yesterday, the U.S. Preventive Services Task Force recommended that women get screened for breast cancer at 40. So they've lowered the age, which is a good thing. And this is really important, especially for Black women. I know we were talking earlier about that, because Black women have a 40% higher mortality rate from breast cancer. Can you
Yes.
elaborate a little bit on the announcement yesterday? And I know there is actually a period now for public comment. Our viewers today may want to make their voices heard as well. So tell me what your insights are about this new announcement.
Well, my training and affiliation has been with the American College of OBGYN, just trained as a gynecologist. And so that's an organization that has recommended annual mammogram screening since age 40, as long as I've been in
Okay.
practice. That would be true of the breast surgeons, the radiology societies. In my mind, they're late coming to the game. The time I hear that screening beginning age 50 is there's always a woman who doesn't trust mammograms or feels like, it's the medical community, trying to pull a fast one on women
Right.
or
Or
something.
it's painful. I mean,
Yeah.
it's
Oh, yeah,
uncomfortable.
there is I just don't like it, which I get that. But I think then the US Prevention Task Force guidelines, you can say there is an organization, but they have really been kind of the latest, least around breast mammogram screening. So I think number one, it elevates the conversation, and number two, it does bring us more all in alignment. I would say most organizations have been recommending it at age 40 for many, many years, but I think this just aligns them. And payers sometimes have looked to them for their payment guidelines. So generally speaking, for preventative care, mammograms have been covered and covered annually for women 40 and over, to my knowledge, as long as I've been in practice. So generally for mammogram screening, that hasn't been a barrier, but I think it's late and it's overdue, and I'm grateful it's another opportunity for women to get the message.
Well, what about women? Many women have dense breasts. How does this new ruling affect them and their need for additional um,
Yeah.
testing?
I think about every state now has enacted a law that requires women with dense breasts be notified in their follow-up letter from their mammogram that they have dense breasts. The frustrating thing is that's half of women. Um, Breast density falls in one of four categories. You're extremely dense, which is about 10% of women. You're heterogeneously dense, which is about 40% of women. So those two categories make up half of
Wow.
women. And there is a correlation with density and age. Mammograms were originally never designed for premenopausal women. Basically, every 40-year-old is going to have dense breasts. So, there is a bit of a rub with our technology of mammogram and the perfection of detection. It is not a perfect test. It's very good, and it's an important screening tool. It's not perfect, and it's less perfect for our younger population and women with more dense breasts. So, tomosynthesis is a version of 3D mammogram is another term for that. In our organization, probably 90% of women are getting those nowadays. We started out just our dense breast, but it's really transitioned over. It's no more radiation. It's the same technique. It's no longer, it doesn't take any longer in obtaining it. So most women are getting tomosynthesis. The problem is the next best screening we have for breast cancer is really MRI. It's really, really highly sensitive. So part of my practice is what we call a high-risk breast clinic. I did some training in cancer genetics, and so I work with a team of people, including our breast surgeon, and we see women who have been identified as having risk factors for breast cancer. So if you have a lifetime risk of over 20%, average is 12-ish, 12%. If your lifetime risk is greater than 20%, you meet qualifications. Generally, insurance will cover a breast MRI for you.
I see.
So, but that takes, it's a computer generated program that makes your breast cancer determination. And then it requires pre-authorization. People have high deductibles, so sometimes they're paying toward that. So MRI, I think emerging technology is being investigated. Contrast mammogram is being investigated. Um, there will be new and better tools to do breast screening, but I don't know when they'll be really accessible to the general public. But mammogram is a really,
Yeah.
really good tool that needs to be better
And I would
utilized.
imagine self-examination too.
Self-exam too, although this was the task force that dropped self-exam from their recommendations about 6 or 7 years ago, thinking women would be worried about it. They don't know what they're feeling. Yeah, again, it's not a perfect world, but we
Yeah.
still, women, again, know themselves and have self-awareness. And if they have something that comes to their attention they're concerned about, of course we want to know about that.
Well, I think, it frustrates me to hear that because, again, first of all, it's such a good thing that we're talking about menopause now more. And to tell women to forego self-examination is like, again, putting this in the closet somewhere. And
I know.
it we should all be doing that. It's like,
I
like you
know.
would look at anything on your skin or,
Exactly.
that looks troublesome. I mean, it's developing that awareness all the time so that you could be an advocate for your own health.
Exactly.
Hmm. Okay. So, Barb, what changes happen during menopause that affects sexual desire and intimacy?
So we understand that the hormonal changes that go along with menopause do impact libido. And the way I say it to women is it's probably not shocking that in the design of our humanness, when we are no longer able to reproduce, we probably lose the drive to do the thing that is now impossible
Right.
for us, right? So there's something human about evolving toward a loss of libido when the physiology is no longer exists. On the other hand, we recognize that in loving, caring, supportive relationships, sexual intimacy remains an important part of the relationship. So outside of the needing to reproduce, we recognize the importance the value it brings to the relationship. So we want it to be able to be possible and comfortable are the two things. So I tell women the context in which we think about libido really needs to shift in menopause, and women are frustrated because at least they're reporting to me, my partner thinks I don't find him attractive, or I'm not as in love, or I'm not as into the relationship, and it's just not true. I just don't need to have sex. It's not a need like it once was. So our old model of sex was the Masters and Johnson model, where what we call a linear model. It all started with desire, which led to physical contact, physical response, arousal, orgasm, maybe, maybe not, and then what we call resolution. Our new model for women, especially perimenopause, menopausal women, is it doesn't start from desire. Generally, women start from a place of neutrality. I could take it or leave it. I'm kind of enjoying my book club book tonight. I'd love to read 3
Right.
more chapters of that, right? So you're neutral. But once you choose the event, once you engage in the event, begin sexual contact, have some physical response, desire then kicks in. So it's a circular model, but not starting with desire, starting with decision, with intention, with mindfulness. So you choose to engage, and then it's probably pleasurable. but it wasn't desire that led you there. So we want women to work from that framework of decision or intention or mindfulness rather than this idea of desire leading you there. Of course, we want it to be comfortable. And so the majority of women over time, in the absence of estrogen, the genitals will be largely impacted, which results in vulvar vaginal dryness, um, narrowing of the vagina, loss of blood supply, which may make arousal more challenging, and just, painful sex. So, and that is what we would call chronic and progressive. So once it begins, it will continue to progress. So women might choose to engage a little less. A month goes by, 2 months goes by. Now it's even more uncomfortable than the last time. So it becomes kind of this dual um, effect of loss of desire, and now it's more uncomfortable. So of course, in many relationships, it falls to the wayside
Yeah.
to some
There's
extent.
so much else going on in life that women are juggling that just
Exactly. Yes. Yeah, and menopause collides with a lot of life, of career decisions and aging parents and, young adult kids, and now there you are looking at your spouse saying, "Okay, here we are now what?" I don't know, it is kind of a calamity of, um, life and physiology.
so what can women do? I know on your website you make recommendations as to certain products that could make having sex more comfortable.
Yeah, so generally we would say start out with moisturizers. So we're busy moisturizing our face and our skin. Well, and the vagina sits there quietly, kind of out of sight, out of mind. So, and a lot of women are single during this season too. So they may have no awareness that things are changing. I just had this conversation with a woman yesterday. She's 55 and menopausal for the last couple of years. And she's been single now a couple of years, but just met a guy. And so we talked about, okay, now, if this relationship leads to this, it may not be what it once was. These are the
Right.
things to think about, let us know. Um, Moisturizers are products that you use on a regular basis, maybe 2 to 3 times a week to try to keep moisture to the vagina. Once there's atrophy or progressed thinning and narrowing, moisturizers can't really restore. So they help retain, but they don't restore a great deal. Certainly, a great lubricant, generally, we'd say silicone. Silicone is more slippery, more long lasting. Water based lubricants are not very good for menopausal women. They tend to be a little gunky. They're drying, actually. The osmolality of it isn't great for the tissues. Um, and so, getting a great lubricant, just plan on it, have it available, keep a moisturizer on board. And then, when those are maybe no longer meeting your need, talk to your provider about it because we have right now 7 different prescription products that are designed to address this. They're all very effective. A variety of ways of administering it. There's one oral, the rest are vaginal. There's creams, tablets, a little suppository. So, a variety of things that can be done generally. Um, and the other thing that's going on now is women aren't having pap smears very often. The pap smear guidelines changed a number of years ago.
Right.
Therefore, they're not having pelvics. There's also a number of vulvar conditions that can arise, but if nobody's looked in 4 years, who knows? So we make assumptions. It's just the changes, which we now call the genital urinary syndrome of menopause, formerly known as vaginal atrophy. Women assume that's what's going on, but maybe there's something else. So a good pelvic exam goes a long way here too, and making sure you're um, having the right treatment plan.
That's really interesting. So what should women do if they have shame about asking or feel uncomfortable?
You know, that's a really good question. I I think that's on the practitioner maybe. I think, generally speaking, it's our responsibility to make it comfortable to have that conversation. Recognizing, some women are, for instance, I have conversations about women using vibrators, and I recognize that for some women, that's kind of a line they maybe aren't comfortable going to or crossing. And I say it in a way of, clinically, we find that they can be a helpful tool, they can improve blood supply, but I recognize this may not be something you're comfortable doing. So I think we have to say it's okay that this makes you uncomfortable, but we're here to talk about it further. And when you're ready to talk about it further and ask questions, please do. And it's funny because my patient population, probably once a day, maybe twice a day, a woman will say, my husband and I just talked a day or two ago because he knew I had this appointment and I knew you were going to ask me some of these questions. So, we talked, and it's like, great. I'm glad this visit prompts you to have to,
That's pretty awesome, I would say.
because mostly
Yeah.
it's something we don't necessarily communicate with our partner about. We haven't had to, maybe everything's happened pretty naturally and responsively. And when that changes, it's hard to have language and conversation, especially in long-term relationships when you've just never had to do that. So
Yeah, I
I,
mean, I also found it easier when I started seeing a female gynecologist versus a male gynecologist, so that might play a role as well.
when I was probably 16 or 17, I was the youngest at home. My mom came home from a doctor's appointment and just kind of rolling her eyes and shaking her head. And she said, he says he knows what I'm talking about, but I know he doesn't know what I'm talking about. And that was the end of the conversation. I didn't ask any questions. She did not elaborate, but I can tell you where I was standing in the house. I can put myself in the kitchen and it made an impact on me.
Sure.
And I now know probably what it was all about. She's no longer living for me to ask that, but I do, again, it's easy for me to say gender matters because, I'm a bit biased, but
But
if
it depends
that's
on the individual. If you feel a
exact
sense of intimidation or discomfort with a male gynecologist, well, then maybe you should try a woman.
yeah, exactly. It would be an oversimplification to say it's all about gender, but maybe for some people it is, in
Yeah.
which case nowadays, fortunately, there are probably as many women practitioners as there are men, and you should be able to access that. There is menopause.org is the NAMS website also has menopause certified providers, and they have a find a provider site where you can put your zip code in and your radius, and they can match you in theory with somebody in your community. And generally, if they have certification in this area, they should be pretty comfortable and do a good job at assessing your symptoms, your risks, um, do an exam, and be able to outline a plan for you to, help meet needs, whether it's menopause, sexually related, more broadly, women's health.
Well, Barb, this has been a fascinating conversation. We're gonna wrap things up, but to close out this chat, we're just wondering if there's anything we can leave viewers with about menopause and what's happening today and what they should be aware of.
Well, as you state that, the first thing that comes to mind is later this month, Um, the FDA is poised to approve. We think this is going to happen. The first non-hormonal treatment for hot flashes. So I think what has come from this elevated conversation around menopause is the research that needs to go along with treatment options. And so what we've come to understand in the last decade is hot flashes originate in the hypothalamus. When estrogen isn't present, certain neurons hypertrophy, become overactive, overfire. It results in hot flashes. Well, our most effective treatment has been add back estrogen. Well, there are women who cannot have it, do not want to have it. Their perception is they don't want to be on it. What can we offer them right now? We have some antidepressants that don't work that great. They have other side effects. There's just a plethora of, I think, snake oil being, sold, and a variety of places. All the claims on the over-the-counter things don't have to have any backing behind their claims. So women are, I think, tired of searching for solutions. So while this product I think is going to be very good, I've seen the data. I've been in, I've watched it carefully over the years. Um, Tolerability looks great. Side effect profile doesn't look different than placebo. It looks effective, but it's just the first. There are others coming behind it. So I think all of this to say is, and maybe the snarky side of this is, well, yeah, pharma's going to figure out how to take advantage
Right.
of these opportunities. But I do think, pharmas save lives, and we're all, we're all here because of pharma, right? So I do think there are going to be some really valuable products that are going to come out of this elevated recognition of the importance of menopause and helping women successfully navigate it. So go to your provider, have a conversation, talk about options, and get moving.
That's great. Well, thank you so much for joining me again today.
Thanks,
And
Julie.
stay tuned, everyone, for another installment of Quorum Live. We'll be back with you soon.